was really angry that I was so sick. It felt really unfair. And I know so many millions of people feel that way. If you can find a way to take all of that anger and fuel it into finding the care that you need, you can feel better. I'm not cured. I'll never be cured, but I'm 31 and I feel better than I felt since I was 14 years old. There is hope to feel better.
Hi, everyone, and welcome back to the Integrative Women's Health Podcast. I'm Dr. Jessica Drummond, founder and CEO of the Integrative Women's Health Institute, and your host for today. I'm thrilled to be joined by Camille Dollins and Dr. Shanti Mohling. We're going to be talking about a patient experience and a surgeon's perspective, especially on extrapelvic endometriosis, which I don't think gets enough attention. And we'll start with, I would love to welcome you and have you share a bit of your story navigating healing from endometriosis.
Yes, thank you for that introduction. My name is Camille, and I'm currently 31 years old. But I have had symptoms of endometriosis since I was 13. Like many, I was diagnosed at 23, so 10 years after symptoms had begun. And I was diagnosed via laparoscopic surgery with my regular gyno. And surprise, it didn't help. And it actually ended up causing a lot of other problems for me. And that was about 8 years ago. And after that, I tried everything to try to manage my pain, try to manage my symptoms. It kind of felt like as soon as I found out about the endo, all of these other problems arose, like interstitial cystitis and just chronic widespread inflammation, as well as like the emotional toll of having endometriosis. Mm-hmm. And then I ended up moving to the Pacific Northwest in 2018 because I knew that they had more integrative care generally, but especially for endometriosis. And I had one surgery with a different specialist in 2019. So my second surgery, who I know was a good surgeon and better than definitely my regular gyno who I had had before that. But that surgeon still did not look in my thoracic cavity when I had surgery. So it was just at a surgery center's pretty standard pelvic endometriosis surgery. That was in 2019. Then middle of 2020, in like the thick of the pandemic, I went back to the same clinic, and instead of seeing the same surgeon, I think he was unavailable, they scheduled me with Dr. Mohling. And they were like, she's brand new, she just moved here. And I was like, whatever. Like I'll see anybody who could maybe help me. And I saw her, and that was the beginning of working together. We tried a lot of different things to manage my pain, to try and see if we didn't have to have surgery again. And I think that went on for maybe 5 or 6 months before we got to the point where Dr. Mohling was like, okay, like something is going on. So I had surgery with Dr. Mohling February 2021. And this was at a time when I remember we were trying to schedule the surgery and like the hospitals were closed, or only emergency surgeries were being allowed to be scheduled. And so it felt like I almost wasn't able to even have this surgery, but I'm so glad that I did, because going into this surgery, I was under the impression that it would be like 2 or 3 hours and a similar pelvic surgery to what I had had. But Dr. Mohling is a very thorough surgeon, and she told me, she was going to look everywhere and take out whatever she found. And she ended up finding extrapelvic endo, specifically diaphragmatic endo, that had been there at least 10 years, that had been missed in my previous surgeries because surgeons don't look, or they're having surgeries in places where they don't have the equipment and the technology to do what they need to do to be able to find that, I don't know, pathology. But she found it. They called my family while they were under. They had to go in through my ribs and do a diaphragm resection. I had nodules full thickness through my diaphragm. It was crazy to wake up in the hospital and have Dr. Mohling tell me all of that, but I feel like a new person, and I am grateful for it every day.
Thanks so much for sharing that, Camille. So, Dr. Mohling, can you tell us a little bit about, from a surgical perspective, when someone presents with endometriosis, obviously the most common place to begin to look is in the pelvic or pelvic abdominal region. What kinds of signs, symptoms, imaging, part of your exam, et cetera, would cue you to consider to look in areas outside of the more commonly understood areas of where endometriosis tends to present?
Yeah, so I think let's first define what extrapelvic disease means. And for me in my practice, how I've come to define it, so pelvic disease would include the pelvic peritoneum, the ovaries, the fallopian tubes, maybe the surface of the bladder, maybe the posterior cul-de-sac, so the peritoneum of the deep pelvis. All of that I would consider pelvic disease. Once you are invading the intestines, invading the appendix, affecting the surface of the diaphragm, or even into the pulmonary cavity, you have extrapelvic disease. If I remember correctly, I am assuming, Camille, since we are doing this public presentation, I can speak about your case freely, but
yes,
we even had some disease, if I remember correctly, on the peritoneum overlying the kidney on the right.
Yes.
So we truly had kind of classic extrapelvic disease. So in terms of extrapelvic disease, we know that endometriosis has been found on the pericardium, which I have removed also. We know that it can be found even in the brain, very, very, very rarely. And then a little more commonly, although still not super common, on the diaphragm, in the thoracic cavity, in the surface of the liver, and also, not too uncommonly, invading into the intestines. Usually the rectosigmoid colon, and sometimes the ileum, which is the area right before the large colon where the appendix comes out, right near the cecum. So that's the second most common place of finding endometriosis. So what I would say is that when I do my intakes and assessment with a new patient, and this is getting back to your question, how do I make that diagnosis? Well, I'm kind of old school. So old school means you actually listen to the patient, you listen to the whole story. And then the patient will give you most of the bits and pieces. And then I make sure that I've heard what happens with your bowel movements and your digestion. What happens? Do you have any coughing? Do you have any chest pain? Do you have any flank pain during the menstrual cycle? More seriously, do you ever cough up blood during your period? That would be it's called hemoptysis, and that's a pretty extreme case. Another thing that can happen when it is on the lung, not necessarily the diaphragm, but the pleura of the lung, you can get menstrual pneumothorax. So the pneumothorax is kind of a collapsing of the lung. And that doesn't just happen from diaphragmatic disease, that happens from pulmonary disease. So all of those chest questions are going to be super important. The bowel questions, the chest questions, and then always in my intake, I include sexuality, pain with sex, pain with penetration, pain with tampon use, and then how's the bladder functioning? What's the general pelvic pain like? So sex, bowel, bladder, chest, and then the final thing is fertility, and that's more pelvic disease, generally speaking. So I take that part of the history, and then I do a very careful exam. And that exam includes a rectal exam and a very detailed interactive exam to understand, is there pain on this uterosacral ligament, this uterosacral ligament, behind the cervix? Is there an obliteration of the cul-de-sac? Can I feel separation between the vagina and the rectum, or is it stuck together? Is there nodular disease? Can I feel anything penetrating down into the rectum? And so it's an uncomfortable exam, except for the fact that it's so interactive, that it's educational, both for me, because I need to know what I'm getting into, and for the patient to understand, oh, this disease is specific. I don't just have this kind of crazy, it's in my head pain. There's something specific going on. I feel a thickening, they feel pain. And so then I begin to piece it together. Disease on the diaphragm is one of the hardest to diagnose and anticipate. And so very often it's found incidentally at the time of surgery. And so sometimes I think it may not be appropriate to just remove it when the patient is coming in for pelvic pain and disease and problems, because there are complications. And as Camille can attest, it can be extremely painful to recover. The recovery is longer than the pelvic recovery, maybe 4, 5, 6 months, even a year, till you finally begin to feel, I'm seeing, yes, this is true. So this is a longer recovery than the typical pelvic disease excisions. So sometimes MRI will show diaphragmatic disease, but really not very often. It is mostly to be suspected and then seen at laparoscopy. And if it's going to be removed, there has to be a really careful conversation ahead of time. And I think that Camille and I did not expect her to have diaphragmatic disease. And so we didn't talk about that specifically, but we had talked a long time about getting every bit of disease, that she was miserable. And it corresponded to flank pain for her in Camille's case.
I mean, I felt like I was dying.
Before surgery.
It was before surgery. Yes, before surgery. Like, it was, I mean, I remember going to you and saying, I just give me a hysterectomy. I don't care. Like, I can't do it anymore. I can't sit. I can't stand. I can't walk. I can't, do the PT that I'm supposed to do, because it hurts to even lay on the yoga mat. And before surgery, I did have an MRI, but it was of my pelvis, because with the pudendal neuralgia that I was experiencing, there was concern about endometriosis being on my nerves and my pelvis. And so, but we didn't do an MRI of my, thoracic cavity, but I doubt that we would have even seen it.
Probably not, although you did have full thickness nodules.
Maybe. I've had so many scans over the years, CT scans, like, I don't know if that would have shown it, but I've been imaged a lot. And there was an incident in college where I was in a class and I had to go to the bathroom, and I blacked out because of stabbing pain, like under my ribs, exactly where this endometriosis was. And my friend had to come get me and take me to the ER, and they did a chest x-ray and basically told me that I was imagining it and that I was crazy. And that was probably, I don't know, 7 years before the surgery that we had. But the only other thing I wanted to add was that the recovery, even from a regular pelvic endo recovery, I would tell people that, like, really it's a 6-month recovery, but maybe even a year to feel like totally 100%. I didn't have surgery. I feel great. For this surgery that I had with the diaphragm resection and everything, I was able to start working out again, really for the first time besides walking, at 1 year. But I would say that recovery took 18 to 24 months, because the whole first 6 months was like relearning how to breathe. And it was really not something that I had anticipated. But like I said, like, relearning how to breathe was so much better than the pain that I was in, because pain like that, like, completely captures your consciousness in a way where there's no space for anything but the pain. So
yeah, I want to add something important, Jessica, before you ask another question, and that is that patients like Camille have taught me over the years, over and over, that the patient will tell you what the problem is, and they will tell you that there is a problem. We just have to find it. And so many patients are gaslit, and you went to the ER with stabbing chest pain, and you were told that you were kind of crazy. And what? You weren't. It was really this really bad disease.
I also had like such bad pain right here, that like would radiate into my neck and shoulders, that 2 years before I saw you, I had a breast reduction because I had so much like chest and shoulder and back and like pain along my ribs on my back, like all of which is associated with diaphragmatic endo. And I'm pretty sure there was also some like pulmonary disease on the outside of my lungs that we all didn't take at the time. But that's something that, I don't know, like all the signs were there, but like I didn't know. I was, it's wild.
Indeed.
Yeah, and that story is so common. I think that's the important benefit of sharing these stories. The work that Shannon Cohn's done with the Endo What and Below the Belt documentaries, and more podcast episodes like this, because the reality is the time to diagnosis is still roughly 10 to 12 years. And think of all the unnecessary procedures and surgeries you had to go through. So, what are some of the kinds of things that you've seen in your practice are so valuable for that pre-surgical and post-surgical support?
Yeah, that's a beautiful question, and I've been thinking about it a lot. Partly because sometimes you remove all the disease, and a person still has pain, and maybe you have a colleague who removed the disease. You go back in, you biopsy a few things, and it looks as clean as could be, and you know that it was fully excised, and yet the person has pain. So sometimes we have to really start to think outside the allopathic box. And because here's what allopathic medicine tells us. Tells us we need to be on birth control pills, continuous birth control pills, which are ethinyl estradiol and some type of synthetic progesterone. So norethindrone, drospirenone, others. Or an IUD with levonorgestrel, or a GnRH analog, which puts us into a temporary state of menopause, really shuts down the hormonal system, temporarily suppresses lesions, but does not eradicate them. And there are others. And so what happens with that allopathic model is you get a temporizing effect that doesn't have any permanent relief. You get terrible side effects. So I would say there's data on the percentage of patients with side effects to GnRH analogs, and not the least of which is bone thinning, which is irreversible. So mood symptoms are primary and predominant, and they sometimes are so intolerable they make patients feel nearly suicidal. So it doesn't seem like a great answer. I also question the whole industry of feeling like all female patients, cisborn female patients, need to be on some synthetic hormone. And so it's a very, very, very common thing that you go to a gynecologist and they say, well, what you need is a birth control pill. Okay, so you asked me, what do I do? Not what do I not do?
That's okay. What do you not do is informative.
I think that sometimes those hormonal pills, like a birth control pill or a progestin-only pill, can be helpful. And if they're well tolerated, that might be one tool. So as I think about it, however, I think that some of the non-allopathic modalities and also physical therapy, which crosses a line into allopathy, can be one of our big tools. So body work, physical therapy, acupuncture, I personally think really good chiropractic can be really great tools to toward not curing the pain of endo, but actually helping the body to function better while it's dealing with either healing from excision surgery or preparing for excision surgery, or maybe you live in a place where you cannot get access or cannot afford access to surgery. So you want to have some type of body work, some type of healing modality. And most commonly, we can access pelvic floor physical therapists, but I think a really good massage therapist, some chiropractors who specialize in pelvic health, and certainly acupuncturists who specialize in pelvic health can offer a significant relief. I also feel I'm a huge fan of diet, and the Western diet is typically not very supportive for an anti-inflammatory condition in our bodies, nor does it typically support a healthy microbiome. So I've done a small pilot study showing an association between impaired intestinal permeability, otherwise known as leaky gut, and endometriosis. It doesn't mean that leaky gut causes endometriosis, and it doesn't mean that endometriosis causes leaky gut. We know there's some kind of association. And I can talk about that at greater length in another podcast, because I can go into a lot of details about that. But that comes down to oftentimes an imbalance in our microbiome. And what's so important about the microbiome? Well, it carries some huge percentage of the DNA that creates the functioning of our systems. So, for example, some of the bacteria in our colon are responsible for maintaining excellent estrogen metabolism. And let me say this another way. There are sort of bad bacteria that will reconjugate estrogens so that they get reabsorbed, elevating the systemic levels of estrogen, which feeds endometriosis. And by the way, also, this has been shown with breast cancer. So, what we need is to have a really, really healthy gut. It's one of the most important things. And how do we get a healthy gut, right? Well, not just taking a probiotic. What maybe that helps a little. Maybe some of that probiotic that we take orally makes it through the stomach acid and actually gets into our intestines. Okay, so I think that fermented foods have a role. But if we are eating a very wide diversity of fruits and vegetables, plant-based foods, 6 to 10 servings a day, we are feeding a healthy microbiome. Most of us have at least some of the good bacteria that we need, and we need to support it and not feed it potato chips and McDonald's, or we all know, and even just frequent processed groovy vegetarian crackers are not as good as eating whole foods and whole fruits and vegetables, 6 to 10 servings a day, and not the same kind every day. We want a diverse collection of these. And unfortunately, a lot of our fruits and vegetables are irradiated, so they also don't have some of the healthy bacteria that we want. So if we have access to a farmer's market, if we have access to organic foods, that's even a step forward. So there's the gut, there's physical therapy elements and acupuncture. And then let's also think about what foods, what substances are somewhat toxic. If you have chronic pain, you have to quit smoking. You absolutely have to quit smoking. You cannot be ingesting all the additives that go with tobacco, plus tobacco and nicotine itself. Okay, so that to me is a given. Pelvic pain and smoking, it does not go together. Alcohol also. And I'm someone who loves to have a little tequila in the evening, but you have to limit it. I feel inflamed if I have too much alcohol myself. I think caffeine is another thing that can be misused. I think that green tea, coffee, these have antioxidant properties that can be really helpful and valuable unless you have bladder symptoms from that. And maybe using it in moderation, not in excess, is helpful in terms of a anti-inflammatory diet. But also caffeine and certain kinds of alcohol, mostly red wine and beer, have very high levels of histamine, which can create an inflammatory response as well. So those are some of the my modalities. And some people, I think, benefit from psychotherapy. When you've been in pain for so long, you cannot help but have depression. There's are even some animal models demonstrating depression related to endometriosis. Just from having endometriosis, you can see in an animal model displays behaviors of depression.
Yeah. I think that mental health piece has been under addressed in the world of endometriosis, because I think as clinicians, there's that carefully fine line that we have to walk, to be mindful of the patient experience, that we don't at all insinuate this is sort of, this pain is all in your head, the gaslighting that people have experienced. And with changes in the
Exactly.
gut microbiome, there, that is one driver of depression. Simply navigating the healthcare system for so long can be a driver of depression and anxiety. And so I think really caring for people's mental health as they navigate this system, as they navigate disease recovery and disease treatment and disease management long term. I think not enough people are talking about that. So I appreciate you bringing that up.
Yeah, and you're absolutely right. It's a very delicate subject because so many of these patients have been told it's in their head, and the prescriptions that they're given are antidepressants and birth control pills when they
Mm-hmm.
have an actual debilitating disease. So it's a delicate balance when you talk about psychotherapy. Another piece I want to add is even to go so far as to address couples therapy. If the
Mm.
patient is in a partnership, having a debilitating disease is very hard on the partnership. And so having mental health support around that can be really important as well.
Yeah, absolutely.
I really appreciate both of you acknowledging this because something that this is just really important to me. I've been in therapy long before I knew that I had endometriosis, but a lot of that was about my health, about having a health problem that nobody could figure out and people didn't believe, and all of that. And the thing about, you tell people that you have endometriosis, and they'll ask you if it is terminal, and
Mm.
it's like it's not, unless there are severe complications. But one of the complications that can be terminal is depression, and
Mm.
like the hopelessness that comes from years and years of being in pain, having surgeries that don't work, changing your diet, like changing everything. I changed my entire life. It's extremely traumatic to have a disease like this, and for myself included, like it has taken a lot of work to acknowledge that and to understand what that means, in my own experience. And the hard thing about this is that, like as I said earlier, it like captures your consciousness, but also like your identity, your entire life, like every single moment you're in pain. I mean, I was in pain every single moment for probably like 8 years, and
Mhm.
like physical pain, and um, you have to, how you eat, how you sit, how you walk, like everything, it just takes everything. And so it after my surgery and I was healing, like, and even before, for years I had done a lot of endometriosis advocacy, and my entire identity had become attached to endometriosis. And as I healed and I got better, which was something that I didn't really know or think would ever happen to the degree that it has, like I've had to do a lot of work, whether it's in therapy or it's almost like soul level work to like understand that the healing from the depression of having endometriosis is realizing that like I did get better. Like I'm not as sick as I was. And I think so many people that have surgeries and have successful surgeries physically that still have a lot of pain, like I think it's really easy to get stuck in that model of like, I'm a sick person and I have pain and I'm always going to have pain. Or does that make sense? Like,
Absolutely.
so like releasing that and like I am healthy right now and I'm not in pain right now. And so that is where I'm trying to live. And I don't want to go on social media and talk about, even though that's what I'm doing right now, but like so many people like are like, I feel better now. Let me talk about how I was in horrible pain for 15 years. Like, I don't know. It's okay to put that down.
Yeah. And because of how the system is, we require so much of people with chronic diseases to do the advocacy work, right? Because no one else is really doing it. And I've definitely seen that over the course of my career that identification with the disease itself can be really challenging, and that sensation that you're very responsible for moving the ball forward and helping the people behind you and all of that. And I think what you're saying, Camille, is so important because people can, even in the midst of chronic disease, fully heal partially, heal some of the time, heal, have better days, have worse days. And you as an individual get to decide. You don't have to carry this whole torch if in this moment you don't want to, or it's not helpful for you. I think that's a really valuable thing to say because I especially think for people of your generation and younger, there's such a deep connection with your how you are in public on social media and all of that. It's almost, again, an integral part of the identity that's you can put it down anytime you want to. And I think that's such a valuable thing to share. So thank you for that. So, Dr. Mohling, let's say you're speaking with, someone who's navigating this challenge of trying to find some skillful support for endometriosis. Ideally, the first thing they would do would be to find your office. But if they either live halfway across the world or they can't for whatever reason, what kinds of things would you encourage people to look for in their surgeon, in the surgeon member of their team?
Yeah. So that's such a tricky thing. Because GYN oncologists are the surgeons outside of sort of these endo specialists within gynecology who have the skill set to absolutely remove endometriosis and deal with this type of disease. But I would say so few gynecologists would remotely touch diaphragmatic disease or invasive bowel disease. So when that occurs, when those symptoms are present, you have to have a general surgeon who's comfortable with that type of disease, with endometriosis. I think also in terms of social media, there has been such a movement over the last decade of educating patients, and patients have educated physicians to realize that we had not been really taking good care of this condition. One of the beautiful things that happened for me early on with social media, using my Instagram platform, I would post about bowel disease or diaphragmatic disease and the extent of it and what can happen and what the symptoms are. And I had a patient from Africa write to me, send me a DM, thanking me because she had seen this information. So she went to a surgeon and said, I think I have it in my bowel. And in her mid-30s, she finally had a bowel resection and finally feels better and had this disease removed. So she knew from social media that she might have this thing. And so she went and found a surgeon who could do it. And it changed her life.
Mm.
in the States, one of the problems is that we have a lot of gynecologists who don't really believe endometriosis is something you should treat surgically, or that it's even really much of a disease. And sometimes it's actually hard to see. It appears kind of atypical. And sometimes I'm even like, God, I hope that I'm doing something right here to help this person, because this looks, that's not that bad. And yet you get the pathology, it's endo, and the patient feels better. So I've learned, it's kind of like my own biofeedback, what to remove. So if you're somewhere where you don't have access to someone who does this every day, you can at least try and get a diagnosis. And then you can begin to work toward how you're going to have it treated. And the diagnosis, like, for example, I think in some of the European countries, you have a lot of gynecologists who know they need to diagnose it. They take lots of photographs, they do a laparoscopy, they make a diagnosis, maybe a biopsy, and then they are sent toward a center where they can actually be cared for. Unfortunately, we don't have that kind of system, and insurance doesn't really pay for 5-hour surgery for advanced extrapelvic disease. So a lot of the docs are out of network, which makes it less affordable. But if you know you have deep infiltrating endometriosis, you do have the option to try and get a general surgeon on board or a gynecology oncologist who might be on board to try and remove your disease. It'll be a little different from someone who focuses exclusively on endo, but it might be beneficial. So I should also add that cardiothoracic surgeons, for the most part, I think, don't believe that we should be resecting this disease and are sort of horrified at what we're doing. And it's their domain. I mean, I'm definitely stepping on the toes of cardiothoracic surgeons when I'm removing disease from the diaphragm. And so often they're the ones who get called when a person has a pneumothorax in the ER and has it because of endo, and they do a pleurodesis, which scars the diaphragm to the lung and don't remove the disease. So the patient may no longer have pneumothorax, but they're still going to have that monthly pain of that endo that's now you can't even find it glued into the thoracic cavity.
The diaphragm, but yeah.
So I think beginning our role is not only to educate other gynecologists, but general surgeons that this is disease that needs to be resected fully and respected, because it can be very invasive and can even completely occlude the bowel. Cardiothoracic surgeons need to understand that this entity causes pain, not just pneumothorax, and that pain is something that we need to acknowledge and treat.
Right. And so I think part of the advocacy that those of us who are clinicians, pelvic physical therapists, nutritionists in this field, surgeons, gynecologists, can continue doing some of that reimbursement advocacy work. And that's some of the work that Shannon Cohn is doing and her team, because I think you're exactly right. The challenge is that within the system, we don't have in the United States very many comprehensive endometriosis centers. There are, and none of them are really like a publicly supported entity. So they're all, private systems. So as we wrap up, Camille, I just want to thank you for sharing your journey. And Dr. Mohling, what else would you like? Is there anything else you'd like to share that I didn't cover yet today?
I think that one of the most important things is that people out there listening to this podcast hear what Camille had to say, that she believed in herself, she knew there was something wrong, and she kept going to find an answer, and she kept until she got treated. And that I think so many, 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 many patients out there are gaslit not by just only practitioners, but by their families, by their mothers who also had painful periods, by their spouses who are tired of them, being in bed for 2 weeks a month, and so having to carry on and believe in yourself and find answers and get treatment is really hard to do when you're in pain. And I think that knowing that there are people out there, more and more people now, doctors, providers who really want to help treat this condition, and that we're there. And I think that there is a role of social media, like you mentioned, Shannon, who is a friend of mine. I adore her. Her work is incredible. She's done a lot in terms of her advocacy to spread this word on such a global level, even. And
Yeah.
and I think Nancy's Nook has done a great service as well. There are over 100,000 people on that site that now have a deeper understanding of this disease. Even I mean, 20 years ago or 30 years ago, when I was finishing my residency, I really didn't think endo was much of a deal. I didn't really
Yeah.
get it. And part of it is that we didn't have as much laparoscopy. So it's much harder to see when you do an open surgery. And now with robotics and laparoscopy, it changes the landscape. We can really identify it and see it in a way that we couldn't a couple of decades ago. So I do think that there has been some progress. And then the final thing I want to say is that if patients are listening to this and they have been asked to do research, one of the reasons we don't have enough research is partly because it's hard to recruit patients. And I know when I did my research with intestinal permeability, there were patients who signed up, but they didn't want to collect their urine for 6 hours. That was just too much of a burden. And so it is very hard, or people don't want to get their blood drawn, or it's too much. They're dealing with pain. And I want to ask people to take that extra step, that if there's an opportunity to be a patient in a research study, that you think about the generosity that is for other people with the disease.
Yeah, I wanted to thank both of you, because I had one of those moments where I'm like sitting here and it's 2024 and I've healed from this surgery and I've healed from all of it, and I'm talking to my surgeon. I mean, and and Jessica, and both of you have helped me. Like, I wouldn't be where I am now without either one of you. And I didn't know that I was going to find Dr. Mohling, and I didn't know that I was going to be lucky enough to work with Jessica after I saw Dr. Mohling. And I saw Dr. Mohling for like 10 months after my surgery for all kinds of like injections and treatments, and like, how do I navigate this? And then after that, I went to Jessica and did her program for endometriosis and nutrition and all of this healing. And like, I just wanted to thank both of you and acknowledge that, like, what Dr. Mohling was saying about having hope and not giving up. Like, I'm really stubborn, and I was really angry that I was so sick, and it felt really unfair. And I know so many millions of people feel that way. And just, if you can find a way to take all of that anger and like fuel it into finding the care that you need, like, you can feel better. I'm not cured. I'll never be cured, but I'm 31 and I feel better than I felt since I was 14 years old. So like, there is hope to feel better.
Yeah.
Thank you.
Yeah.
Well said.
Thank you so much for saying that. Yeah. Well, thank you so much for being here, both of you. Camille, your story is so inspiring and hopeful. And I think it's also a credit to you, as you said. I mean, you have to have tenacity in the system that does not respect. We live in an ableist society. We live in a healthcare system that's very difficult to navigate and very expensive and requires a lot of labor on the part of the person who is sick. And so you've done a lot of that work, unfortunately, but it served you well. And Dr. Mohling, I think you are really being innovative in the space of surgery, not just surgery and surgical techniques and looking beyond the pelvis, but having that collaboration with integrative clinicians like myself and pelvic physical therapists and other manual therapists to really think about the pre-op and post-op experience from a complete mind, body perspective. So thank you for sharing that.
Thank you. Thanks. And thanks for your work as well. And it's a pleasure having the conversation today.
All right, great. Well, we'll put all your links in the show notes. Thanks everyone for being here, and we'll see you next week on the Integrative Women's Health podcast.